Hi everyone. So factor disorders are going to be what we're talking about here. And there are a lot of factor disorders. So not all of these are particularly due to intrinsic factor disorders themselves, but some of them are due to other bodily dysfunctions that can cause a decrease in the factors. So pretty much what we're going to talk about here are genetic diseases that can cause a deficiency of factors, or predisposing conditions that can affect the production of factors. But all of these will relate to factors to one degree or another. What they also have in common is because they are factor disorders, they all have factor type bleeding as a possible presenting symptom, usually as a presenting symptom. And factor type bleeding is a little bit more severe than regular platelet type bleeding. With platelet type bleeding, remember, those are superficial bleeding, so particularly your purpura, petechiae, ecchymoses, prolonged bleeding during menstruation, nosebleeds, possibly bleeding in the urine, and so forth. With factor bleeding, we're looking at more deeper bleeding. So hemarthrosis, deep hemorrhages, bleeding into organs, CNS bleeds, so a little bit more significant. So hemophilia A and hemophilia B, the reason I group these together is because clinically they're identical. The only way they're different is how we treat them. So both hemophilia A and hemophilia B are X-linked recessive bleeding disorders, and they're caused by a deficiency of factor VIII or factor IX. And a deficiency of factor VIII is hemophilia A, and a deficiency of factor IX is hemophilia B. They're both X-linked recessive, and clinically they're indistinguishable. So because they're X-linked recessive on the USMLE and in real life, you're primarily going to see this in boys. And primarily, you're going to see this in young boys because hemophilia A and B both are something that you're born with, and so they will present at a very young age because bleeding is something that can happen at any point in your life. So the symptoms are going to be weakness and orthostasis, and that can be due just to coincidental subclinical bleeding, where over time the child or patient is losing blood and eventually becoming anemic. Joint pain, warmth, stiffness, those are all related to hemarthrosis, which is sort of your classical symptom of factor type bleeding. And so you can get the joint pain and warmth if you have an active bleeding into the joint, and then sort of stiffness can be a sign of chronic bleeds into a particular joint. You can get a chronic inflammation. Anytime you bleed into a joint, you are activating the inflammatory pathway. Headache, stiff neck, irritability, meningeal symptoms would be signs of a CNS bleed. Hematemesis, melena, BRBPR, those are signs of GI bleed, and epistaxis. So not all of these are necessarily going to coincide in the same patient, but what you should be aware of is that hemophilia A and hemophilia B, being factor diseases, are going to have factor type bleeding, so particularly hemarthrosis and deep hemorrhages. So the classical presentation on the USMLE, and nearly half of the presentations in real life, is in the neonatal period. So young boys who hemophilia is almost always in young boys. You'll do the circumcision if that's what's requested by the parents, and there will be a prolonged bleeding, and that has to do with the factor disease. And so significantly prolonged bleeding after a circumcision can be a presentation of hemophilia A or hemophilia B. But not always. Certainly there are boys who don't get circumcised, and so they might not be discovered that way. And so a lot of cases are discovered as hemarthrosis, particularly in 1-2-year-olds when they start walking and they're falling down. they can get trauma and hemarthrosis from that. Notably, in hemophilia A and hemophilia B, there's not going to be any petechiae, purpura, and ecchymoses. Those are platelet-type bleeds. So with the factor diseases, hemophilia A and hemophilia B, you have perfectly intact platelets. Your platelets are working and you have enough of them. So you can form that initial plug and you can form that the beginning of that fibrin mesh. However, the problem comes from when you want to form that mature cross-linking in the fibrin mesh, and so the actual the clot is not completely stable. So that's fine for superficial things. We only need an immature clot or a unstable temporary clot because healing is faster in the superficial tissue. However, in the deeper tissue, healing takes longer, and so we need a stronger clot. And it's the factors that help us, particularly factor 13, but all of the factors that help us form that mature, stable clot. And so any of the factor disorders are going to cause deeper bleeds, but they're not going to cause petechiae, purpura, or ecchymoses because your initial stages of clot formation are sufficient for that, and those aren't affected in hemophilia A or B or any of the factor disorders. So as far as how we diagnose hemophilia A and B, based on the symptoms, particularly ecchymoses, bleeding in young children, young boys, especially if there's a family history, remember, because it's X-linked recessive, it's going to be in mom's family, and so it's going to be like maternal uncles or possibly grandpa has the hemophilia, and by diagnosis, we need to get basic labs, coagulation studies, and factor assays. And so any place where we're thinking possibly factor-type bleeds, basic labs, coagulation studies, and factor assays are all going to be critical. So we need the basic labs because we need to check the CBC for anemia. That's just part of doing a basic workup. We need to get the coagulation studies because that's going to tell us if there is increased bleeding time, if there's elevated PT or PTT, which sort of gives us a hint of if there's a factor disease or not. And then the factor assays will specifically tell us what factor is deficient if there is a deficient factor. So your CBC is often going to show iron deficiency anemia, and that's just due to your subclinical bleeding. Coagulation studies are invariably going to show an elevated PTT, but a normal PT and a normal bleeding time. So why is it an elevated PTT and a normal PT? So you need to know about your intrinsic and extrinsic pathways. So your intrinsic pathway is what measures PTT. And intrinsic pathway is mediated by 12, 11, 9, 8, and 10. And so when we're talking about deficiencies in factor 8 and 9, those are going to affect the intrinsic pathway. With the extrinsic pathway, which mediates our PT, that's simply mediated by factor 7. So with hemophilia A and B, you're going to have an intact PT because factor 7 is fine. But you're going to have a prolonged elevated PTT because you either have a deficiency of factor 8 or 9. So factor 8 deficiency, remember, is hemophilia A. Factor 9 deficiency is hemophilia B. Both are X-linked recessive. And they both cause the same symptoms. The difference is how they're treated. So the treatment in the emergency department, you need aggressive hemostasis, which should include bandaging and immobilization, particularly if you've got hemarthrosis. Emergent imaging is absolutely necessary, especially if there's any kind of trauma. And what I'm talking about here is head trauma. So you're going to want to have a head CT in cases of head trauma because that's going to impact the level of emergency that this is. Of course, if it's a bruising, or sorry, if it's a bleeding into the joint space of the knee, yes, that's emergent, but it's not a critical emergency. If you've got a subdural hemorrhage, that's obviously a critical emergency. So imaging is going to be important in certain cases. Administration of factor 8 or 9 should only be done in the emergency department if you know that the patient has a history of hemophilia A or B. So if the patient says that they have hemophilia A or B, or if they've got one of those little medical bracelets that say hemophilia A or hemophilia B, then yes, you can replace factor 8 or 9, and you don't necessarily need to get all of the workups. But on the USMLE, they're generally going to want you to they're going to want you to know how this is done. So you're going to need to know factor 8 or 9. You've got to get the or you've got to get the workups for hemophilia A and B. So a lot of times they're not just going to tell you you've got a patient with hemophilia A or hemophilia B. So you should know how to work these patients up. But in real life, a lot of times the patients are going to know their disease, and if they come into the ED, you don't necessarily have to get the whole workup. As far as in the hospital, you want to treat any kind of complications. You don't necessarily have to admit all these patients, but obviously if they have a head bleed, a lot of them need to be admitted. If they've got severe hemarthrosis, they're going to need to have that immobilized, and you're going to need to extract the blood. And you also want to admit them in cases where you need to ensure their stability. On an outpatient basis, as far as treatment, we use prophylactic factor 8 for hemophilia A, marketed as Helixate and Zintha, and that's particularly for hemophilia A. Factor 8 is not going to be useful in hemophiliacs B because they've got intact factor 8. So prophylactic factor 8 for hemophilia A, and that's just replacing the deficient factor. DDAVP is also useful in patients with factor 8 deficiency. Remember, we also use DDAVP in von Willebrand's disease, and that's because there is an association between factor 8 deficiency and von Willebrand's deficiency. Generally, patients with hemophilia A do have an intact von Willebrand's factor, but DDAVP is also used for hemophilia A. For hemophilia B, we use prophylactic factor 9 on an outpatient basis, marketed as Nixabis. And so this is these are patients that generally don't respond to DDAVP. There has been some experimental therapy with DDAVP. Some physicians like to use it, but what you should know for the USMLE is factor 9 for hemophilia B. So factor 8 for hemophilia A plus DDAVP, and factor 9 for hemophilia B. On a just sort of consular knowledge, they should know to avoid high-impact contact sports, which would make sense that since it's trauma that causes a lot of the injuries and the bleeding, and any kind of activity that poses a high risk of trauma. All right, so here's a picture of a very severe hemarthrosis in the knee. And what you should know is that it's primarily the weight-bearing joints that are going to be the ones prone to get the hemarthrosis. So you're not going to see hemarthroses in your fingers, in your metacarpal phalangeal joints, in your wrists. You're going to see them in your ankles, in your knees, possibly in your hips. So here's another less severe one in the right ankle. And then here's a very severe one in the knee. And you can even see scars, I think. It looks like scars from possibly where they've gone in to drain the joint before. I don't know if that's necessarily what that is, but it's possible. Okay, hemophilia and Queen Victoria. So remember, hemophilia is an X-linked recessive disease, so you get it from your father. And the British royal family and all the royal families in Europe, a lot of them are inbred to a certain extent because the old idea was that you should keep royal blood royal and not marry out to the peasants. And this later became a big problem for them because you can see here on these pedigrees, some of them were marrying their cousins, Henry of Prussia and Irene here. And so there were lots of affected males. These gold-colored boxes are males that died, or males that had hemophilia, and a lot of them died at a young age. So one died at 20. These both bled to death after accidents. One died at 4, another died at 3. So you can see that this X-linked recessive disease is obviously worse if you're inbred. Later, we've come to know that, and so now there's no hemophilia present in the British royal family because they're marrying out to quote-unquote peasants. So, a little bit of a historical connection here. And this is Queen Victoria and her big, huge royal family, a lot of whom are inbred hemophiliacs. So vitamin K deficiency, just as its name implies, is a deficiency of the fat-soluble vitamin K. It's due to malnutrition or which is often secondary to malabsorption. So in the U.S., it's generally due to malabsorption, but you can also see it due to malnutrition, particularly in alcoholics. So vitamin K is necessary for the production of factors 2, 7, 9, and 10. And so malabsorption, you should think like cystic fibrosis, celiac disease, inflammatory bowel disease, or biliary disease. So what do you need to absorb fat? You need your lipase, pancreatic lipase. You need liver enzymes, and you need a intact bowel. So with cystic fibrosis and with biliary disease, what you're getting there is not enough enzymes to break down fat. And so in that case, you've got malabsorption due to low fat absorption. With celiac disease and IBD, you've got destruction of the intestinal wall. So in that case, you can't absorb vitamin K because your intestine is diseased. And so both of those lead to malabsorption. Either whether it's because you can't absorb fat, which vitamin K is fat soluble, so you need to absorb fat to absorb vitamin K, or if it's due to a diseased intestine. A lot of times you're going to know the underlying cause just based on the patient's history. But it's good to know that anything that causes malabsorption can cause vitamin K deficiency, as well as deficiency of the other fat-soluble vitamins A, D, and E. Malnutrition, particularly, we think of alcoholism. So these are the causes of vitamin K deficiency, particularly in adults. The site of absorption for vitamin K is the terminal ileum, so particularly we think of Crohn's disease when we think of vitamin K deficiency because Crohn's disease affects the terminal ileum. In the United States, vitamin K deficiency is primarily encountered in neonates, particularly in premature neonates, and that's simply because their vitamin K absorption is not quite mature yet. So the symptoms of vitamin K deficiency are, again, factor type bleeding, similar to hemophilia. However, superficial bleeding can be encountered in vitamin K deficiency as well. But this pretty much just looks like hemophilia, and it makes sense because you've got factor deficiencies, and so it's going to affect that pathway. How do we diagnose this? Well, with any kind of factor type bleeding, we need to get routine labs, coagulation studies, and factor assays. So in vitamin K deficiency, you're going to have deficiency in factors 2, 7, 9, and 10. And the coagulation studies will show a prolonged PT and often a prolonged PTT. Now, it's not always the case where you have a prolonged PTT. It may be high normal, but you're always going to have a prolonged PT. And the reason is because with the extrinsic pathway that affects the PT, it's just factor 7. So if you're deficient in factor 7 and you don't have, and that's the only factor important for the extrinsic pathway, well then the PT is going to be affected significantly. So what you're normally going to see in vitamin K deficiency is a very affected, very prolonged PT and a normal to high normal PTT. So the PTT may be high or it may be high normal, but the PT is going to be significantly high. Now, the bleeding time, of course, like in any of the factor diseases, is going to be normal. Remember, the bleeding time is just an analysis of the platelets. So if the platelets are normal in quantity and normal in quality, then your bleeding time will be normal. And your CBC may show anemia just due to a chronic blood loss. So how do we treat this? Oh, well, let me go back first to the most sensitive test for vitamin K. You don't necessarily get this in the hospital. I've never ordered it. I've never seen it ordered. But the USMLE often likes to ask you, what's the initial test? What's the most sensitive test? And so the most sensitive test for vitamin K deficiency is a DCP level, which stands for des gamma something prothrombin level. Don't worry about that. It's a DCP level. So if you really are a 99 percentile person, put that on a flashcard. Treatment for vitamin K deficiency is based on the severity. So if there's severe bleeding, definitely you should be treating that with fresh frozen plasma, and then the administration of either oral or parenteral vitamin K. If it's just mild to moderate bleeding, and when I say mild to moderate bleeding, what I'm saying basically is non-life-threatening bleeding, then you can treat simply with oral or parenteral vitamin K replacement. It doesn't take a lot of vitamin K to restore normal function. So it's important to remember, though, that in the patients that do have deficiency in absorption, that you're going to need to give them a vitamin K preparation that is water soluble. So either whether you're giving this parenterally or orally, it doesn't matter, but if you're giving it to patients with malabsorption, you need to give them a form of vitamin K that can be absorbed water solubly. So if they have, and let me say, if they have malabsorption due to fat malabsorption, not due to inflammatory bowel disease or celiac disease. So if they can't absorb fat, you can't give them an oral preparation of something that requires fat to be absorbed. Let me put it that way. But in general, what you should remember is fresh frozen plasma plus some kind of vitamin K replacement, usually parenteral, but it can be oral. Just make sure you're giving them the right oral preparation. Foods rich in vitamin K, any of your dark green vegetables, and then other vegetables such as tomatoes, olives, squash, peppers. Okay, factor deficiency secondary to liver disease. So if you go back and think, what are the factors that are deficient when you have vitamin K deficiency? That's 2, 7, 9, and 10. When it's liver disease, the deficient factors are 2, 5, 7, and 10. So the way I remember it is liver disease affects factor 5 because liver has 5 letters, whereas vitamin K, it doesn't affect 5. So vitamin K is 2, 7, 9, and 10. That's how I remember it. Take it or leave it. So in patients that have factor deficiency secondary to liver disease, you're going to normally know this because the patient has a significant history of liver disease, and you'll have this in their chart. So a lot of times they'll have a history or symptoms consistent with liver disease, so chronic alcoholism, cirrhosis, ascites, jaundice, hepatomegaly, and so forth. Symptoms, as far as the bleeding goes, any kind of bleeding is possible depending on the stage of their liver disease. So if they have rather early liver disease, a lot of times it's just going to be factor type bleeding. If they've got late liver disease or very progressed liver disease, a lot of those patients will actually also have thrombocytopenia. So it can kind of confuse things a little bit as far as the symptoms. But just pure factor deficiency secondary to liver disease is going to be primarily factor type bleeding. The type of bleeding is generally GI bleeding, and so that probably has to do something with the fact that the liver affects the GI system, and since so if the liver is diseased, the GI system is going to be diseased, and if you've got a diseased GI system, it's predisposed to bleed. So some of the things that you might see are things like variceal bleeding. And so that's probably part of the reason why GI bleeding is the most common organ system that bleeds in liver disease. But you should know that factor type bleeding, platelet type bleeding, they can both happen in liver disease. As far as how we diagnose this, again, routine labs, coagulation studies, factor assays. Your CMP will give you some hints of the liver disease in as much as you'll have elevated liver enzyme. Your CBC will show anemia. Your platelets should be normal unless it's very late liver disease that can result in thrombocytopenia. Coagulation studies will show an elevated PT and PTT, although the PT is more severely affected. And again, it's due to the fact that factor 7, if it's deficient, it's going to cause a significant effect on the PT. It also has to do with the fact that factor 7 has a shorter half-life. So factor assays will show deficiency, of course, of factor 2, 5, 7, and 10. Factor 5 is going to help you differentiate it from vitamin K deficiency. As far as treating factor deficiency secondary to liver disease, if it's emergent, you're going to be taking steps necessary to stop the bleeding. So, for instance, if they have active varices, then you need to do an EGD with banding or sclerotherapy. Fresh frozen plasma should be administered in any kind of significant bleeding, and as far as long-term therapy, you want to treat their liver disease. So treating their hepatitis, treating their cirrhosis, and so forth. Disseminated intravascular coagulation is probably one of the most dramatic factor deficiencies, and it has many different possible causes. But what you get in disseminated intravascular coagulation is a widespread clot formation and an exhaustion of the factor supply. So basically what's happening is that you're getting, usually it's tissue factor, but you're getting some kind of stimulus that's causing your factors to interact with your platelets spontaneously. And this happens, like the name says, disseminated, so widespread, and it eventually exhausts your platelets and your factors. So you get these disseminated clots that form all over the place, random places in the body, but you also get bleeding because you have exhausted your factor, and so now you are going to get bleeding in all sorts of different places. So you get organ damage due to the clots, and you get bleeding due to the fact that you have exhausted your factor supply and exhausted your platelets. So there are a lot of different possible causes, but once DIC has occurred, it looks pretty similar. So we're really not so much concerned about the potential etiologies in the very, very acute phases of treatment. We're more concerned about stabilizing the patient. However, as far as treatment, like a lot of things, the underlying cause is something that needs to be addressed. And so you need to be aware of some of the possible etiologies. And some of those etiologies include namely sepsis, trauma, cancer, a lot of obstetrical calamities like placental abruption or a fat embolus. The symptoms of DIC, as I've kind of alluded to, are going to be bleeding, either platelet or factor type. Remember, we are exhausting both our platelets because of the clot formation and our factor because of where the factor is what's being stimulated to form these clots. So we can get petechiae and purpura, and then we can also get, due to the clots, acral cyanosis, skin necrosis, gangrene, symptoms of renal or hepatic dysfunction due to distal emboli. And then, of course, the signs of the possible underlying cause. So if it's a pregnant woman, then yes, you think of a placental abruption. If it's somebody who has got, on labs, has elevated white blood cell count, then we think possibly of a septic infection. So here's some causes of DIC. Sepsis and trauma, I would say, are the most common. Malignancy can be any kind of malignancy, but particularly remember M3 AML is a common cause of DIC. Abruptio placenta, toxic immunologic causes, snake bites, transfusion reactions. Obviously, these are much less common. Kasabach-Merritt syndrome is a common cause of DIC in young children and infants, and that's a hemangioma that can lead to DIC. So again, diagnosis here is routine labs, coagulation studies, factor assays. With DIC, a D-dimer can be useful. D-dimer just measures clot breakdown. So anytime we're forming clots, we're also breaking them down. And so when you break down clots, you get a D-dimer. Your D-dimer goes up when you break down clots. And so if your D-dimer is elevated, it shows that you have clots and you're breaking them down, which is normal if you have clots. The major differential diagnosis is going to be between DIC and ITP, which is idiopathic thrombocytic purpura, and TTP-HUS, which is thrombotic thrombocytic purpura hemolytic uremic syndrome, often secondary to a E. coli. So with ITP, I addressed this in the platelet type bleeding section. There are very few abnormalities apart from increased bleeding time and thrombocytopenia. And what ITP is it's an idiopathic consumption of platelets. The macrophages are eating platelets, and so you have a low platelet count. And because you have a low platelet count, you're going to have an increased bleeding time and, of course, thrombocytopenia. TTP-HUS is going to be an increased bleeding time and thrombocytopenia. However, with TTP, you're getting hemolysis, so you're getting destruction of your red blood cells because you have clots distally. So those clots are going to either destroy the red blood cells or they're going to deform them. And so if you get destruction of the red blood cells, which you always do in TTP-HUS, you're going to get elevated bilirubin. And the red blood cells that just get damaged, they will appear on a smear as schistocytes. You also have evidence of thromboses, and then you'll have a normal PT and PTT. Because in TTP-HUS, it has nothing to do with factor. It just has to do with the fact that you're getting clots of platelets, and it has to do with a metalloproteinase called ADAMTS13. And what that is it's a protein that cleaves von Willebrand factor. So it has nothing to do with platelet, or it has nothing to do with factor. All it is a protein that's supposed to cleave von Willebrand factor. If you don't have that protein, then you can't break down von Willebrand factor, and so you're going to get these big blocks of platelets that are connected with von Willebrand factor, and that's TTP-HUS as far as the mechanism. But it has nothing to do with factor, so your PT and PTT will be normal. Nevertheless, because there is thromboses, you are going to get microangiopathic hemolytic anemia, so you'll have the elevated T-bili, the schistocytes, and then the thrombocytopenia and increased bleeding time. Now with DIC, you're going to have all the features that you have in TTP-HUS because you have thromboses, and so you're going to be destroying your red blood cells to a certain extent, and so you're going to have the elevated T-bili, possibly jaundice. You're going to have thrombocytopenia because you're overusing your platelets. You're going to have an increased bleeding time because your platelets are deficient because they're being used. But you're also going to have a prolonged PT and PTT because the etiology of the DIC, the cause of it, is the fact that you're consuming your factor. It's not because you can't cleave von Willebrand factor, it's because you're consuming all your factor, and so now you don't have any left, and so your PT and PTT are going to be abnormal. They're going to be prolonged. And a lot of times DIC is in the setting of sepsis, whereas a lot of times with TTP-HUS, you're going to see it in a patient with either a recent or current history of E. coli 0157H7. So as far as treating DIC, pretty much what the USMLE wants you to know is the emergent treatment, and you just want to make sure that you're maintaining fluid status and finding and correcting the underlying cause. In the case of active bleeding, fresh frozen plasma is a safe choice. Platelets can also be considered, but fresh frozen plasma is more established because we're replacing the factor that's deficient. In cases where thromboses predominate, unfractionated heparin can be considered, as well as TPA. But what do you need to know for the USMLE? Know the emergent treatment based on fluid status and treating the underlying cause and fresh frozen plasma. That's most important. All right, so I wanted to address some of the drugs that affect the coagulation cascade. So we'll start with heparin and low molecular weight heparins, and then we'll talk about warfarin. So heparin and the low molecular weight heparins are commonly prescribed as prophylaxis for vascular episodes, so patients who have had heart attacks or strokes. It's given during acute coronary syndrome, so NSTEMI, STEMI, and unstable angina. And then it's often given for the treatment of deep venous thrombosis and pulmonary embolism, as well as during certain procedures. So the mechanism of heparin and the antiheparins or the low molecular weight heparin is to activate antithrombin 3. And antithrombin 3 is an enzyme that blocks thrombin. So antithrombin 3, when it's activated by heparin, the activity increases, and so it blocks thrombin more. And so when it blocks thrombin, it blocks the coagulation cascade, because this is the common pathway once we get to thrombin. So the result is going to be a prolongation of both the PT and the PTT, but when we are assessing therapy, we are going to follow the PTT for heparin. So we measure the PTT when assessing therapy with heparin. The major side effect of heparin is heparin-induced thrombocytopenia. That's just an autoimmune reaction where it's inducing thrombocytopenia, and so the heparin is causing a reaction where the platelets become consumed, become macrophaged, and so your platelet level drops. And so when you start a patient on heparin, you should be monitoring their platelet counts. And the heparin-induced thrombocytopenia is something that happens during the initial stages of heparin commencement. So if the patient does have heparin-induced thrombocytopenia, you should immediately stop the heparin use. And we've kind of gotten away from seeing heparin-induced thrombocytopenia because we've been using the low molecular weight heparins, and these were developed, this was part of the reason why these were developed. Low molecular weight heparins like Lovenox and Oxaparin are less associated with the heparin-induced thrombocytopenia. Heparin overdose is treated with protamine sulfate, and that's just a little piece of quiz that you should know for the USMLE. So a lot of times this is an intentional overdose. This is iatrogenic overdose, where the physician just prescribed too high an amount of heparin. Warfarin is an oral medication that is commonly prescribed as a prophylaxis for embolic events, particularly AFib, where they've got a CHADS2 count that's high enough to indicate prophylaxis, valve replacement, and then it's also used in the therapy of DVT, pulmonary embolism, and in the post-MI stages. So the mechanism of action for warfarin is basically to antagonize what vitamin K does. So it blocks the activity of factors 2, 7, 9, and 10. Now it also inhibits protein C, but this is not part of why warfarin works. So warfarin blocks 2, 7, 9, and 10, and that inhibits the coagulation cascade. But remember, protein C and protein S are also active in this, and protein C and protein S are procoagulant. So what protein C and protein S do together is that they inhibit factor 5 and inhibit factor 8. So here's the problem. If you're inhibiting protein C and protein S, you do have a procoagulant factor to the procoagulant side to warfarin. And that can be a problem because protein C and protein S are actually what are inhibited first, along with factor 7. And so, since you are blocking protein C and protein S first, you can get this warfarin necrosis. And that's basically what's happening is you're starting the warfarin and you actually procoagulate the patient in the initial stages rather than anticoagulate the patient. And so in the initial stages, we want to keep an eye on this, but a way we can prevent this is to start with using heparin first, because heparin doesn't cause that. And so we start with a heparin or a low molecular weight heparin, which is kind of inconvenient because it has to be taken subdermally, but it doesn't cause this necrosis. So you start the patient on a low molecular weight heparin for a few days, you get them anticoagulated enough, then you can start them on warfarin without the concern of procoagulating them by inhibiting protein C or protein S. And, sorry, that should say procoagulative properties there, not anticoagulative properties. Okay, so with warfarin, we're going to be monitoring the patient's PT during therapy, and PT is a measurement of the extrinsic pathway. We measure PT with warfarin use just because factor 7 is going to be important in the factor 7 is uniquely inhibited in warfarin use. So we monitor the PT during therapy with warfarin. A lot of times this is done via the INR, institutionalized normalized ratio, and all that is the patient's PT divided by a normalized PT. And in a normal patient, of course, that should be 1. So just to recap, all of these are going to be normal platelets because these are not platelet disorders, with the exception of DIC, and that's just for the fact that the platelets are being consumed. So with hemophilia A and B, we've got everything normal except for the PTT. The PTT is elevated because it's affecting only the intrinsic pathway. The PT is normal because it is not affecting the extrinsic pathway. Vitamin K deficiency, it's affecting both the PT and the PTT, but the PT is elevated because factor 7 has a shorter half-life, and so with vitamin K deficiency, you're going to first see elevations in your PT, and it's going to be more pronounced. It's pretty much the same story with liver disease. The PT is going to be more pronounced than the PTT. However, both PT and PTT are usually elevated. With DIC, everything's awry. So you've got an elevated bleeding time because you're consuming platelets. You've got elevated PT, elevated PTT, and low platelets. You're also going to see schistocytes on your smear, and you're going to have anemia. With heparin use, we see an elevated PT, elevated PTT, but this is therapeutic, presumably, and the platelets are going to be normal unless you have heparin-induced thrombocytopenia, which would warrant cessation of the drug. With warfarin, you're going to have, again, elevated PT, to a lesser extent, elevated PTT, and remember, for therapy, with heparin, we're going to be following the patient's PTT. With warfarin, we're going to be following the patient's PT or INR. And that's it.